Our next speaker is Erika Sterling. Um, Erika has been a nurse for about 15 years, working in various fields such as cardiology, non-invasive cardiology, cardiac rehab, cardiac cath lab, cardiothoracic ICU. She is currently working as a heart transplant coordinator at Henry Ford Detroit Hospital.
Thanks, Rebecca. Hi, everyone. As Rebecca said, my name is Erika Sterling, and I am the site coordinator at Henry Ford Wyandotte for vascular surgery. Rebecca asked me to speak on my experience and some of the insights I gained at our last in-person meeting back in October. I really enjoyed the networking and the breakout sessions with especially other team members from Henry Ford, as well as coordinators who have been working on some of the same QI projects as myself at the hospital. It's good to hear other people's challenges, the same challenges that we're experiencing, knowing that it's happening at other places and not just at our hospital. So I'm going to go over the two quality metrics that I really gained some insight on at this last in-person meeting. The first one being smoking cessation. I really enjoyed the presentation that Milani gave regarding that and all her work that she did on the order set for smoking cessation within the Henry Ford system. System-wide, so it's nice that we at all the hospitals have access to use this. Um, when we were behind in that metric, I went to our physicians. They saw the reports and were surprised by it because many of them said, we talked to all our patients about smoking cessation, before, after, but what it came down to was documentation. And while some of them will put a small blurb, smoking cessation discussed with patient, it's not enough to meet the guidelines for the quality metric. So I was able to speak with Milani, and she sent me her tip sheet, which I then went to our ICU at Wyandotte. We just have the one ICU where typically all our patients go after their procedure. And I was able to post those. I sent them out to our physicians. Some of them being surprised, the all the things that needed to be documented in order to be receiving credit for it, but they found it helpful. Um, so after reviewing, putting these into place and reviewing our last quarter, still noticing that we're not quite hitting our metric. Again, talking to the physicians and looking through the patient's charts, I'm realizing that it's not always our vascular surgeons that are speaking and writing these notes for discharge or, the final days that they're at the hospital. So I've put into place or I'm going to begin haloing some of the residents. I think that with our revolving door of residents and fellows coming in and out, it is being missed because once you have a group of the residents and fellows on board, next thing you know, they're no longer working in vascular surgery or with our cardiologist. So that's going to be a next step that I'm going towards. And at our hospital, we don't have as many cases as many of you do. We are only abstracting for CAS and CEA, so for the carotid procedures. I am able to follow the patients and see who is still smoking at the time of the procedure, and then make sure I'm reaching out to the residents or the fellows who are following those procedures post surgery. So while it may not be beneficial to all the hospitals who might have a larger caseload, I'm hoping that it will be helpful to us in that sense. So we'll see going forward how that works, and I would be happy to report back to anyone who thinks that this is hopefully going to be a solution. The second quality metric that we have been having a hard time with since pretty much I started, and we weren't doing quality improvement projects right when I started. We've only been abstracting for BMC2 and vascular surgery since about 2023, but it is CA opioid naive patients being discharged with less than four opioid pills. Um, I spoke to Kyle at that last meeting in October. He stated that his facility had been having some of the challenges and they have been overcome. He helped me set up a snap board so that, again, I could follow these patients, see who's having the procedures for the week. Sometimes, I follow it daily. Other times it's just on a week basis, depending how many cases we have. And again, reaching out to these residents who are prescribing the opioid pills. I originally spoke again to our vascular surgeon, and he stated, my team, I am not the one prescribing these. So I had to go speak to the ICU director, talk to them about ways of overcoming this, and realizing it's the residents and fellows who are prescribing them. So I have implemented this as of recent, and I'm happy to say that while abstracting for this last quarter, I finally, for the first time, as far as I can remember back, had a resident prescribe less than 4 pills. And I do remember haloing this specific resident. So it was really nice to see that some of these strategies are, in fact, working to help us achieve these quality metrics. I hope it continues. I was very excited. I even contemplated reaching out to this resident to tell him how excited I was that he actually took my piece of advice. So moving forward, I thank everyone who helped me at the last meeting and gave me some of your tips and strategies that you use. It was very beneficial. Now this next slide that I'm trying to get to is, I guess, a next topic that I would like to discuss with fellow coordinators in an area that it's not a quality metric, but it's an area that sometimes I find challenging having to work with vascular surgeons and interventional cardiologists. My physician champion is an interventional cardiologist. So sometimes when it comes to um, metrics that just are based off our vascular surgeons, it's hard not having a surgeon in place as that physician champion. My champion is willing. He brainstorms with me and we'll discuss, ways that we could possibly make this better. But again, it's hard not having someone who is actually doing those type of cases. Um, it just seems there's this divide, this disconnect between the two specialties, maybe even some tension where they're not always willing to reach out and speak to one another. I'm more so the middleman trying to put it together between the two and make these metrics work. So I'm looking forward to at our next meeting, maybe talking to some other people who have had these challenges, have found ways to merge the divide. I have researched it, and I know some facilities are using, hybrid ORs. And while I don't think that's anything that may ever happen at our facility, just finding some collaboration between the two specialties. Um, so with that being said, in conclusion, I truly enjoy these in-person meetings we have. I know sometimes we have to drive a long ways and, get out of the house but it's really a time to reconnect and support one another. I value the perspectives that come from other coordinators. It fosters a sense of collaboration within this community that we have. And being a smaller hospital, I sometimes feel that I don't have as many people to reach out to within my hospital. So it's nice having other Henry Ford team members I know that are so willing to help, and go over their experiences with me. And as far as the BMC2 organization, I truly value working with you all as well. Rebecca and Pam, Molly, you've always been so great when I've had struggles with finding a physician champion or, data fields, anything. You're always there to help, and it's greatly appreciated. So I just want to say thank you to everyone, and I look forward to hearing from all of you in the future.